We are not operating using a playbook that exists. We're writing the playbook.
I rely on my team to come to the table, be prepared, be creative, build that level of trust within the team. The patient is always the heart of every decision. We need to make that difference in a patient's life, to give them a little bit of their life back. We owe it to them.
We chose to focus on the most common forms of limb girdle muscular dystrophy to start, which encompasses about 70% of the limb girdle population, and that is LGMD 2A, 2B, 2C, 2D, 2E, and 2L.
LimbGirdle.com is a resource for the community. The site offers education, highlights free genetic testing programs, and allows U.S. residents to request to receive updates from Sarepta. We welcome everyone to join today.
Welcome to today's webinar, Understanding Limb Girdle Muscular Dystrophy, Help for the Newly Diagnosed. My name is Catherine Bryant, and I'm the founder of the Speak Foundation. And in just a moment, I'm going to introduce Dr. Matt Wicklund, who is our speaker for today. I'm very excited to have all of you with us. I want to talk to you today and tell you that today's webinar is sponsored by Sarepta Therapeutics. Sarepta Therapeutics has brought together the elements essential for development of gene therapies: productive collaborations, unparalleled scientific understanding, and an unwavering sense of purpose. Sarepta has 5 LGMD gene therapy programs in development, including for subtypes 2E, 2D, 2C, 2B, and 2L, and holds an option for a 6th program for LGMD2A. I also want to share that there are free resources for you if you are still undiagnosed. The program I want to share with you today is called Detect Muscular Dystrophy, which is sponsored by Sarepta. The Detect MD program provides diagnosis for individuals who are suspected of having a muscular dystrophy by offering the following services at no cost to the patient or provider. This program includes free genetic testing with multiple testing options, including the 30+ genes for LGMD, a specialized program to resolve variants of uncertain significance, otherwise known as BUS, family variant testing, patient-ordered testing option through a genetic counseling telemedicine service, post-test genetic counseling for patients to review and explain the genetic test report. The program eligibility: you must reside in the US and Canada and be suspected of having muscular dystrophy with one of the more of the following: progressive muscle weakness, elevated CK levels, cardiac or respiratory involvement, cough, hypertrophy or pseudohypertrophy, muscle biopsies showing dystrophic changes and or immunohistochemical evidence for specific muscular dystrophy subtypes, family history of muscular dystrophy, clinical diagnosis of LGMD or your diagnosis yet to be confirmed through genetic testing, or previous genetic testing with uncertain results. You can find out information about this important program at invitae.com, Detect Muscular Dystrophy. There you can download a form to take to your doctor and start the patient-initiated process. Thank you so much. And at this point, I'm going to go ahead and introduce Dr. Matt Wicklund, a neurologist at the University of Colorado Neurosciences Center. He is also the professor of neurology at the University of Colorado School of Medicine. A graduate of University of Colorado School of Medicine, he has over 30 years of practice, teaching, and publications in neuromuscular medicine. His clinical and research interests all aim to help patients with neuromuscular disorders, including muscular dystrophies, genetic muscle diseases, and neuromuscular weakness. He is a member of GRASP LGMD, and he is considered one of the nation's leading experts on LGMDs. Dr. Wicklund, thank you so much for being with us today. And at this point, you can go ahead and start sharing your slide deck with our audience.
Well, then let's get started. It's great to have you all here with us today. We're We're going to walk through a little bit about the limb girdle muscular dystrophies and then things that might be important to you when you're initially diagnosed, which I hear many of you may be. So here we go. All right. So let's start off, and on patients that are newly diagnosed, I like to start off very simple. So we're just going to talk about muscle. And so there are 3 types of muscle. There are skeletal muscles, and those are the ones we usually think about that move the arms, the legs, etc. There's cardiac muscle, so the muscle involved in moving of the heart. Smooth muscle, which is the muscle that moves the gut. And then there's sort of a 4th muscle that we think about, 4th type of muscle, and that's the respiratory muscles. Those are really skeletal muscles, but the diaphragm and the muscles that move the chest wall all are involved in that bellows action that move the lungs. So again, just very basic. Muscle is like you see there in the diagram. It's a muscle which is a bicep muscle. And those are composed of fascicles. Those are little subsections of a muscle. And many of those contain many muscle fibers, which are the individual contractile elements that are involved in a muscle. And each of those have very specific small pieces which are myofibrils, and those are the ones that do the actual contraction in the muscle. So muscles are composed of fascicles, which have many fibers, and they have myofibrils, which are the contractile component of muscles. So to the limb girdle muscular dystrophies, back in 1954, Lord John Walton at Newcastle and Fred Natras proposed the limb girdle muscular dystrophies as a separate, distinct entity other than the 3 most common of the muscular dystrophies. And the most common muscular dystrophies at that time were Duchenne muscular dystrophy, myotonic muscular dystrophy, and facioscapulohumeral muscular dystrophy. And once you had these 3, there were a number of patients that were left that had some other type of a muscular dystrophy, and they all became limb girdle muscular dystrophy. The way we talk about limb girdle muscular dystrophies is that they are genetically inherited conditions that primarily affect skeletal muscle, leading to progressive, predominantly proximal muscle weakness, and that there is a loss of muscle fibers as the cause for that weakness. And there are several items that are required for a limb girdle muscular dystrophy to be called a limb girdle muscular dystrophy. They must be described in at least 2 families that are unrelated. And that's because there's some very rare forms that we've had that are only described in a single family. And so we really need more to be involved. Individuals at some point in their life achieve independent walking, and that's to distinguish them from some of the congenital myopathies and congenital muscular dystrophies. They have to have an elevated muscle enzyme level at some point. They must demonstrate degenerative changes on muscle imaging, which can be ultrasound or CT or MRI. And then they reveal a dystrophic pattern on muscle biopsy. So the limb girdle muscular dystrophies all have a relatively similar appearance, but there are different genes that are responsible for the different limb girdle muscular dystrophies. And so from left to right, we have a person that has the first person actually is Becker muscular dystrophy. The second person has FKRP. The third person is a young man with a sarcoglycanopathy. The fourth has a calpainopathy. And the last one on the right there is a person that has dysferlinopathy. So this busy cartoon is a way of showing that if there is a defect in a gene that's responsible for a protein that is anywhere in or around a muscle fiber, it can lead to weakness and lead to a limb-girdle muscular dystrophy. And so there are, on the bottom right there, nuclear envelope proteins that are involved in limb-girdle muscular dystrophies. To the left of that, you'll see lines that are intersecting that are the contractile apparatus that can lead to limb-girdle muscular dystrophies. There are intracellular proteins just above the nucleus, you'll see that. In the middle of the diagram, you see the sarcolemma, which is the muscle membrane. And in the middle of that, you'll see the red and blue, which are mostly structural proteins that help hold that muscle membrane together. To the left of that are some gold circles, which are 3 different proteins that are involved in trafficking and repair across the membrane. On the right again, outside of the muscle fiber, there's the extracellular space, and that's where a lot of the alpha dystroglycanopathies, so FKRP and similar disorders, are located. And even all the way out beyond the muscle fiber in the connective tissue between the muscle fibers, the collagen disorders, collagen 6 and collagen 12, can be involved in causing a limb-girdle muscular dystrophy. This diagram shows that although there are multiple overlapping phenotypes associated with numerous genes, the limb-girdle muscular dystrophies sit at the center of this, and there are other genes that can either be close in appearance to a limb-girdle muscular dystrophy or can have more than one name. So some muscular dystrophies that are limb-girdle muscular dystrophies are also distal muscular dystrophies. Some that are LGMDs are also congenital muscular dystrophies. Some are disorders that are involving the contractile apparatus. And so this is just a diagram to show that many different disorders fall into that general rubric of the limb-girdle muscular dystrophies. And this kind of gets us to where we are roughly today. There are more than 26 autosomal recessive limb-girdle muscular dystrophies, 10 autosomal dominant limb-girdle dystrophies, and many other genetic muscle disorders that can cause a limb-girdle pattern of weakness. And therefore, in my mind, when we see a patient, have to be at the forefront of what we're thinking when we're looking to diagnose a patient with proximal muscle weakness. And you'll see at the bottom there are more than 150 genes that are involved in genetic muscle diseases. And that's why many of the panels that we use now for genetic testing incorporate 100+ different genes. And in the next year or two, likely will expand to involve maybe close to 1,000 genes that we'll be looking at. All right, nomenclature. In the old days, this is what we had. I showed this slide multiple times from when it was much shorter than this to where it is now, and now it's even bigger. And these are the limb-girdle muscular dystrophies. But at the top, you'll see LGMD1 and then a letter, and it goes from A through I. And then in that lower section on the left, you'll see LGMD2, and then it goes from A down to Z. And we have a problem when we get to Z, which is no one knew what to do with the next limb-girdle muscular dystrophy that was discovered that was recessive because we ran out of letters. And so there is an old way in which we talk about the limb-girdle muscular dystrophies. And in the old, it was as I had on that previous slide. LGMD1 stood for dominantly inherited limb-girdle muscular dystrophies, which means that it passes from generation to generation. And you would have, if you have a dominant form, you would have gotten it either from your mother or your father, and one of them more likely would have been affected, either your mother or father would have been affected, and you would have a 50-50 chance of passing that on. And then there was the LGMD2, which is recessive, which means that mom had a copy, dad had a copy, and you just happened to get both of the bad copies. And when you get both of those, then you have the limb girdle muscular dystrophy. And that also, on the positive side, means that you would only pass one of these on to one of your children, and therefore the likelihood of your children having the same limb girdle muscular dystrophy are relatively small. And then we always put a letter at the end of LGMD1 or LGMD2, and the letter was a designation delineating the order in which the chromosomal locus was discovered. So LGMD2A was calpainopathy, LGMD2B dysferlinopathy, and we'd gotten all the way to LGMD2Z, which was POGLUT1, which is one of the alpha dystroglycanopathies. So our colleagues in Europe met in 2017 and came up with a new nomenclature. And so you'll see the old nomenclature and the new nomenclatures for describing limb girdle muscular dystrophies. And in the new nomenclature, you have LGMD, and then it's either D for dominant or R for recessive. And then you get a number for the order in which the gene was discovered. And the advantage of that is you don't run out of numbers because they're infinite. So we could go to, well, actually, there are only 20,000 genes, so we probably will not get beyond 20,000. And then there is the affected protein. Some genes that previously were called limb girdle muscular dystrophies were transitioned to other categories of genetic muscle disease, like the myofibrillar myopathies or the distal muscular dystrophies. And so currently, the nomenclature for that first one that we had before, LGMD2A, which is calpainopathy, is now called LGMD. 2A goes to LGMDR1, calpain 3 related. And then there are other disorders that were not officially called limb girdle muscular dystrophies, such as Bethlem myopathy, which now has become LGMD D5 collagen 6 related. So this sort of sums up the way that it looks now. We have the LGMD-D, or dominantly inherited, in that smaller category. And then we have the LGMD-R. And as you can see at the bottom, we have gone past the POGLUT1 related because we added in recessively inherited collagen 6 disorders and laminin alpha 2 related disorders. So how common are the limb girdle muscular dystrophies? This is a genetic testing program that occurred between 2013 and 2015 and was sponsored by the Jane Foundation and the Muscular Dystrophy Association. It was through the Emory Genetics Lab. And there were 4,600 tests that were performed on people that were thought to have a limb girdle muscular dystrophy phenotype. And in that, we were able to delineate that the most common of the limb girdle muscular dystrophies in the United States are the calpainopathies, followed, as you look on that graph, to the second one, which is the dysferlinopathies. And then if you take all the collagen 6 disorders together, because there are 3 genes that make up collagen 6, that becomes the third most common. And then you have the sarcoglycanopathies, anoctamin 5, and FKRP that follow right after. And those are the most common of the limb girdle muscular dystrophies in the United States. Our European colleagues in concert published from their genetic testing program, which was a few years after that program. And their numbers are quite similar in that calpainopathies are the most common. Dysferlinopathies are the next most common. Anoctamin 5. They included titin, which wasn't included in the first one. And then we have the collagen disorders and sarcoglycans. And then really, what is the prevalence? And that's a really tough one to answer because until you test everybody, you cannot know the answer to that question. And so the mechanism by which published estimates have been obtained include, for example, in the north of England around Newcastle, because they have the national health system, they know that the people that are in a certain region will go to just this one central location. And they were able to delineate that there were 2.3 per 100,000 that had limb girdle muscular dystrophy. In the Netherlands, they calculated that it was 1.5 roughly per 100,000. And these are all minimum prevalence estimates because these are only people that have presented and been diagnosed. Whereas those who are previously undiagnosed, such as many of you maybe 1, 2, or 3 years ago, you still had what you had, but you were not part of this, part of any calculation. And so in the US, we figure there are roughly 3 to 10 per 100,000, which means maybe 10,000 to 30,000 people who have limb girdle muscular dystrophy. I'm going to briefly walk through the most common of the limb girdle muscular dystrophies here in the United States, and then we'll move on past that. So the most common, as I mentioned, was calpainopathy. It probably makes up maybe 10 to 15% of all the cases of LGMD in the United States. It's inherited in a recessive fashion most of the time, but there are also autosomal dominantly inherited, which means it passes generation to generation. Most patients present between 5 and 20 years of age is when their illness will start, their weakness. And it has a very distinct pattern. And that distinct pattern is, as I'll tell you in a moment, but if you look at that portrait of that gentleman, that came from the very first article written about a large population back in 1996. And you look at their quadriceps, so the front part of their thigh, it looks like a normal bulging part of a thigh in a young man. But if you look at the back part, the hamstrings, they're all scalloped out. And so that is the pattern of weakness in this disorder. The quadriceps remain quite strong, but the hamstrings are very weak. The hip flexors that allow you to lift your leg at the hip are very strong, but the hip extensors are weak. And the muscles that move your leg outward, kick your leg outward to the side, are strong, but to pull it back in are quite weak. And I remember a 19-year-old young man who had continued to play basketball in high school because his quadriceps were so strong. And in the exam room, he could do 10 deep knee bends without any difficulty. He could squat and rise, squat and rise. But then I asked him to stand and just lift his heel up off the floor by bending his hamstrings, and he literally could not lift his foot up off the floor. He was that weak in his hamstrings. So they can be quite disparate. And then the muscle enzyme level in this disorder is usually in the low thousands. And on muscle biopsy for us, they often have this lobulated appearance in their muscle fibers. So in that small picture, there are muscle fibers that are sort of uniformly colored, and then there are some that look almost like popcorn in appearance. All right, the second most common, and actually if you're on the West Coast, probably the most common because it's more prevalent in those of Asian and Hispanic Mexican extraction, are the dysferlinopathies, and it probably makes up 8 to 10% of the limb girdle muscular dystrophies. It has a later age of onset, usually in the teens to 20s. And in this one, most patients have some involvement, not just of the thighs, but also of the calves. So the calves get a little bit weak along with the proximal muscles. And there can be differences from one side of the body to the other, those asymmetries. There tends to be no real cardiac or pulmonary involvement in this disorder. The muscle enzyme level can be elevated to very elevated, meaning 20, 25, 30, 35,000. And about 50% of patients at some point in their lifetime will require a wheelchair to help with their mobility. The next is the sarcoglycans, and this probably makes up about 5 to 10% of all limb girdle muscular dystrophies when you combine the 4 genes that make up this group of disorders, the sarcoglycanopathies. It tends to be a younger onset, most of the time in the first decade, occasionally in the second decade. The phenotypes can be that very early and rapidly progressive in a young child, sort of a Duchenne muscular dystrophy-like, but it also can be later, coming on in the teens or 20s or later. Cardiac involvement does occur in this disorder, and so that has to be monitored. The muscle enzyme levels, once again, are elevated, and many of these patients who have sarcoglycanopathies will wind up using a wheelchair at some point in their life. As you can see from the pictures here, this is a disorder that has quite a range of onset, and this is called FKRP, or Fukutin-related protein. Again, it makes up 5 to 10% of limb-girdle muscular dystrophies. It is actually one of the most common of the limb-girdle muscular dystrophies in those who are of Northern European extraction. It can present, and this is how it was published, when it was initially published in, I believe it was 2003, there was an article about a congenital form. So you see that little baby that's quite floppy and can't raise his arms or legs up off the bed. And then a month later, they published about their patients with a much milder form, like this young lady here, who is a teen, and she's relatively strong, but she's not as strong as her peers. This disorder can have cardiac and pulmonary involvement, and sometimes that can be relatively early. And then for those that have onset in the single digits, they generally will be using a wheelchair at some point in their life. Now, switching from young to old, well, older, the LGMD2L, which is R12, which is enoctamin 5. This was published initially in the late 2000s. And this is a very common disorder in the north of England. It's about 5 to 15% of LGMD. The reason I put that broad range, as we'll see a little bit later, is that by genetic evaluation, this may be the most common of the limb-girdle muscular dystrophies, but currently it still is not the most prevalent when we look at those that have been diagnosed. Tends to have a later onset, 20s, 30s, maybe 40s. There is more frequent involvement in males than females, and the males that do have enoctaminopathies are weaker than females. And in this disorder, as you can see from the pictures, on the upper left there is a patient that has significant biceps weakness. If you look at the bottom, that's a patient of mine who was a former power lifter when he was in his 20s, because he was a very good athlete. And when he was in his 40s and 50s, he started developing his weakness. And a little bit smaller and perhaps a little bit tougher to see are the MRI images, but they simply show that there is involvement of the hamstrings and then involvement of the calves. There is some cardiac, but no real respiratory involvement in enoctaminopathies. The muscle enzyme level is usually in the low thousands. And most patients are ambulatory, but they can have significant functional limitations 10, 20, 30 years into disease. And then finally, we haven't really talked about any dominantly inherited, and that's because currently about 85 to 90% of all patients who have a limb-girdle muscular dystrophy have a recessive form that we've diagnosed. So the most common of the autosomal dominantly inherited disorders is actually the collagen 6 disorders, which is Bethlem myopathy, but of the original LGMDs, DNA JB6 is the most common. It's about 3 to 5% of all LGMDs. Onset tends to occur in a range, but it can be teens and early adulthood. There's proximal muscle weakness. There is distal weakness in some, and it's a slowly progressive disorder. And the muscle biopsy has unique features in that it has these things called vacuoles, which those arrows are pointing to, which are small little areas in the muscle fiber that are sort of a degradation material that's in that muscle fiber. So now we're going to kind of walk through things that I think would be helpful for you if you're newly diagnosed. So if you're newly diagnosed and you want to know more, what should you do? The internet's great nowadays. So here's my answer. Of course, we're speaking for the Speak Foundation, so I would go to the Speak Foundation website. They have a lot of useful information and they're great in terms of advocacy. There's another website that I like quite a bit, which is LGMD Awareness Foundation. This is a more European website, but it includes those from the US and from Europe. It's lgmdinfo.org, and it discusses how to get access to most of the advocacy groups for each of the individual LGMD subtypes. Of course, the Muscular Dystrophy Association is very helpful, and their website has quite a bit of information related to the limb-girdle muscular dystrophies. And then the National Organization for Rare Disorders has information about limb-girdle muscular dystrophies. If you're more interested in sort of the science and research behind your disorder, then there is a very nice website called the Neuromuscular homepage. And that website is in sort of a bulleted fashion, but it will talk you through all sorts of information about your disorder. And it's a common sort of organizational pattern that this author uses, and that he talks about genetics, which sometimes is a little bit uber geeky and hard to get through. Then he'll talk about the protein, which once again is kind of complicated. But then he does a good job of talking through clinical features of the disorders. And then he'll talk through the laboratory features, imaging, biopsies, and then any sort of treatment if there's treatment available. The next one is gene reviews, and this is very helpful. It talks about individual disorders, each of the individual limb-girdle dystrophies. We've already mentioned Sarepta Therapeutics. They have a nice website that will take you to information about the limb-girdle muscular dystrophies. And then the GRASP LGMD website, which has some information and also talks about research associated with the limb-girdle muscular dystrophies. Of course, there are a number of specific organizations that are involved in advancing knowledge and advocacy about individual limb-girdle muscular dystrophies. And I've listed these here for the ones that I was able to come up with. And so there are quite a few. The most common of the limb-girdle muscular dystrophies have these. And then I've listed a few others of disorders that often are in the LGMD or limb-girdle weakness phenotype, such as RYR1 or VCP. And then some of the distal and myofibrillar myopathies are on there also. All right, you're diagnosed, now what? And the answer is you need to get optimal care. And so I'm going to go through a few things here. So management of the limb-girdle muscular dystrophies currently involves supportive care. So I'm going to go right to the bottom where it says there are currently no FDA-approved medications for the limb-girdle muscular dystrophies. We may be a year or two away from that, but right now there are none. So the key is you need multidisciplinary care, and that involves PT, OT, orthotics, and that's for mobility, pulmonary and respiratory therapy, which is involved in making sure the lungs work as well as they should, cardiology, if your disorder has cardiac involvement, orthopedics and pain management for some, and then management approaches aim to improve quality of life and prolong survival, and then genetic counseling. I like this. This comes from a different disorder, but it encompasses everything you need for the limb-girdle muscular dystrophies. The way we think about care is we have the patient at the center. And then in that first circle around that are all the care providers that are physicians that are involved in your care, which could be neurologist, pulmonologist, cardiologist, geneticist, pediatrician, depending on age. And then certainly really important is to have a very good primary care provider. And then there are other therapies that are very important for your optimal outcome in life, and that includes respiratory therapy, physical therapy, occupational therapy, etc. And so a good multidisciplinary clinic will hopefully allow you access to these care modalities. Just to give an example, And it's easy to talk about our clinic because our clinic is the one I know, though I've been involved in other clinics. But in our clinic, we have a clinic that's multidisciplinary where, as you'll see on the left, we have neuromuscular providers, a genetic counselor, a nurse and a clinic coordinator, our therapists, our social worker, a nutritionist, and then importantly, somebody that provides durable medical equipment and also an orthotist. And then we also have collaborative agreements with a number of other specialists and our pulmonologist, and you'll see I said neuromuscular pulmonologist. And the key there is you don't usually, if you have limb girdle muscular dystrophy, need a lung doctor. What you need is a doctor that understands how the lungs are moved, and so the bellows component of it. And we have somebody that sees somebody the same day as we are. They're just 3 floors up from us, and we coordinate appointments. The same is true with our cardiologists. And then we have gastroenterologists, endocrinologists, orthopedic surgeons for scoliosis if needed, an ENT. What sort of evaluations should you have? And the answer is you should think about in clinic having evaluation for falls, and then evaluations by your neuromuscular provider, physical therapy and occupational therapy. And then on a research basis, many of the multidisciplinary clinics will do assessments that are able to be followed over time. Pulmonary, it's very important to have an initial set of PFTs at the onset. And then when you do pulmonary function testing, if you can encourage your providers to do both upright and supine testing of your breathing, that can sometimes find early weakness in the supine position, or it can assess how well you can breathe when you are sleeping at night. And then sleep medicine, if you have daytime hypersomnolence, frequent napping, morning headaches, any of these, then you definitely need to see a sleep medicine doctor. And as people have heard me say, what you really need is you need a BiPAP trial or some sort of a AVAPS trial. CPAP does not work well when you have respiratory muscle weakness in most patients. If your disorder has cardiac manifestations, you should be evaluated by a cardiologist. And then subsequent evaluations depend on if your testing is normal or abnormal. If it's abnormal, they'll probably follow you every 6 to 12 months. And if it's normal, they can repeat the testing in 5 to 10 years. Bone health is very important. So it's good to have a bone density test. And then also if there's scoliosis or rigid spine, you should be seen by orthopedics. And of course, we talked about earlier, there are equipment needs that sometimes come up as disease progresses, and that can be handled by a durable medical equipment provider and an orthotist. And finally, genetic counseling is important because, especially at the time of diagnosis, they can talk about risks to other family members, risks for future children, preconception counseling, if that's an issue that somebody would like to discuss. And then there can be pre-implantation testing if a partner is a carrier. Nutritional medicine is also important. And we also make sure that we do evaluations for swallowing troubles and then for gastro and for GI issues as they come up. All right, you're diagnosed, what can you do? And there are opportunities to advance science. Registries, here's my push. They're easy, they don't take a lot of time, and they're very, very valuable. So if there's a registry, sign up. And the reason for that is most of the LGMD subtypes have some sort of registry. And like I said, very little effort, but it provides significant metadata. And also it allows you to be contacted if you so choose for any research opportunities that are out there in your LGMD subtype. I'll bring up our GRASP LGMD Research Consortium. Our goals are to accelerate clinical trial readiness for treatment trials, work on discovery of other genes that are involved in a limb girdle phenotype. Because currently, if you do genetic testing, it's only about 40 to 50% of patients will obtain a diagnosis through current testing. We're doing variant resolution for those, and many of you may have been in that position where at some point you had what's called a variant of undetermined significance. And then we're looking for what else makes some patients more affected and others less affected. These are the sites that are involved in the care, and I listed them from west to east. So they span from the West Coast all the way to the East Coast. And there are also 2 sites in Europe, in Newcastle and then Copenhagen. How do you find research opportunities? Probably the best place to look will be the clinicaltrials.gov. GRASP LGMD Research Consortium talks about what trials we're doing. And then the Muscular Dystrophy Association does have a clinical trials finder program. All right, here's the last few slides, treatment. So we already talked about supportive care, and that's very, very important. And it's important whether there's gene-based therapy or not. But let's talk a little bit about where we're headed in terms of gene-based therapies. So many of the treatments that are coming out are viral vector gene-based therapies. And it almost never sounds good to say, especially in the COVID era, I'd like to get a virus, please. But you do want to get a virus, please, if you're getting gene-based therapy. And just to look at that little diagram, so often we use adeno-associated viruses. And what that top is just a picture of the virus. Right below that is what the DNA looks like in that virus, if it's a virus that can cause an infection. It has a rep, which is a replicating sequence, and it has a cap, which is the coding of the virus. And so it's a very simple, small DNA piece. And so all that happens is we cut out that replicating gene and the cap protein gene, and then we introduce our own LGMD gene into that virus. And that virus then serves as a vehicle so that it can take the genetic material to you so it can be used to produce the protein that you are missing. This is an example of that. If you look on the left, you have an AAV particle that has a limb girdle muscular dystrophy gene in it. There are receptors on muscle fibers, and that middle is a muscle fiber. The receptors take that virus and they bring it in. This virus then translocates into the nucleus, which is that center portion there. It then releases the DNA, and the body's own machinery inside a muscle fiber nucleus will then make that single-stranded DNA into a loop of double-stranded DNA. We call it a plasmid or a mini chromosome. And then that can make protein, and that can make protein for, we don't know quite how long, but in large animal models, it is for not days, weeks, or months, but years that it'll exist in a muscle fiber. And what that shows us on the right side here is it restores the LGMD protein that's missing. And this is an example of a sarcoglycanopathy. So it is a protein that's at the muscle membrane. So it's around the edge of fibers. And in the left 3 that are dark, those are the patients before they were treated. And then on the right, where you see the red sort of circular areas, those are muscle fibers that now have the sarcoglycan back. And so it's quite effective in allowing production of protein and restoring, hopefully, the function of those muscle fibers. I'm going to end with something that happened to me now. It's about 8 years ago. I had a patient who was in his 50s, had had a limb girdle muscular dystrophy for nearly 40 years. He was in a wheelchair, and he asked me this question, which caught me off guard at first. He said, I can barely move my arms and my legs. When they come back from the war, they've lost their arm. Can't you give me a new arm? You can take my arm off and give me a new one. And I said, I don't think we can do that. But it got me to thinking. And back in 2012, I said, well, who can regrow arms? And that's right, salamanders. So why is this relevant? And the answer is because up until 2016, we knew that salamanders could regrow arms, but we could not make the salamander regrow the arm. In other words, we didn't know the mechanism. And what we found out is that it's actually a 2-gene mechanism to turn on regrowth of arms or limbs in a salamander. And in that little figure there, if you turn on one gene, you get this little bleb that's blue and you don't get regrowth of an arm. If you turn on another gene, you will get a little bleb that's green in there and you don't get regrowth of the arm. But if you turn on both at the same time, then you get complete regrowth of the limb. And so while this is not a 2020 sort of therapy that's out there, it may be a 2040 or 2050 therapy. So something to keep in mind, that science is still advancing and there are things that we can do now that we couldn't do 20 years ago, and there will be things 20 years from now that we'll be able to do that we can't do today. So thank you for listening to this talk. Hopefully it was informative and I appreciate it, and I'll welcome any questions.
Great job, Dr. Wicklund. And we do have quite a number of questions. So I am going to get to them so that everyone's question can be heard. And our first question is from Felix, and he said, at what age do you tend to see muscular dystrophy not being diagnosed? So I think he's saying, what are the upper age limits where you don't see it diagnosed?
It is so variable with the different subtypes. My answer to that is it's I think almost harder in older patients than in younger patients, especially if somebody has onset with a more slowly progressive limb girdle muscular dystrophy in their 40s or so, because at that age, and I'm older than that, you start saying, oh, maybe it's just because I'm getting older. And so for the first 1, 2, 3, 4 years, you just assume you're getting older until all of a sudden you realize, no, I'm not even close to my peers. Something must be going on. So I think I would say that if you're young and you're significantly affected, generally it'll happen more quickly, though there still are delays, especially in the very young. So, infants that are walking but not quite walking normally, it can take 2 or 3 years before the pediatrician goes, no, they've really fallen off the curve.
Okay, good answer. We have a question from Renee. For LGMD2A, do you talk about the possibility of wheelchair use? This individual, I'm sure, is newly diagnosed and is asking a question about that possibility. Yeah.
So the answer is, I probably would not talk about it at the first visit, but we do always talk about it. And the reason is because I'd have to go back to my slide, but there is a not small number of patients with LGMD2A that will wind up needing a wheelchair at some point in their life. And it should be thought of, the way I think about wheelchairs, and I don't use one, is that it really is an alternate means for mobility. It's really not that, this is something that's limiting your life. This is something that will be augmenting your ability to maintain a functional lifestyle going forward. So even though it's scary to think about a wheelchair, those patients and colleagues of mine that are using a wheelchair, they say that that's their means of just remaining active in life.
I like that answer. And I also feel, as a patient that does use a wheelchair, I was so reluctant, but then when I started to see that it would open up my life and I'd have more freedom, I was willing to use it. I think if you don't need one, you shouldn't use one. But
that is correct.
Because you won't want to use one because you don't need it. But as your body develops weakness, you'll start to think of other means. And I thought of it just like you said, this is a transportation mechanism.
Right.
And we don't make people without disabilities walk everywhere. We give them cars. And so this is the way I was able to adapt to it emotionally. And it really did help me a lot to handle it that way.
Yeah, and I'm just going to say the way you described that is perfect. So when patients start telling me they're not doing certain things that they want to do because of their mobility, then it's easy to talk to them about a wheelchair.
Yeah, exactly. And for me, I think it was my mother was in the hospital and I wasn't able to go to see her in the hospital room because I couldn't walk into the hospital. Usually somebody would have to come out and help me get there and hold my arm. And that was when I realized, there might be days when I actually need to be there for someone and I can't be there. And that's what helped me to realize I could use this device and be there for more people in my family. And that was what encouraged me to do it. We have a question from Macy Jackson. When diagnosing LGMD, are there any major differences in symptoms between LGMD and polymyositis or other autoimmune causes? I'm still waiting on genetic testing. My neurologist thinks I have LGMD, but I also have a topical form of scleroderma, so I'm not sure.
That's a really good question. Probably the means that is most helpful, the most helpful is the genetic testing being positive, but it's usually the time frame. Most of the acquired autoimmune disorders tend to have a time frame that is in weeks, months, or a year or two, whereas those that are a limb girdle muscular dystrophy tend to have symptoms when they, especially I'll ask patients, when you look back in your retrospectoscope, when do you think that this started? And they'll often say 3, 5, 7 years ago. And that's a long time for some of our autoimmune disorders.
Thank you so much. We had a question from Renee, and she wanted to know, would your slide deck be available? And we will actually publish this webinar on the Speak Foundation platform. It's actually on YouTube. And you can also access it from the speakfoundation.com website. And you can also see the whole GRASP LGMD series that we have. So we want to say thank you to Sarepta for being a sponsor for that. I also have a question from Macy Jackson. And how long do you think it will be until a gene therapy for some forms of LGMD? And when might they be approved by the FDA?
So that's a good, so I'll be an optimist and then a realist. So the optimist is there have already been gene therapy trials that show that there is good transduction and protein production in humans through systemic gene therapy for some of the limb girdle muscular dystrophies. So I think that we're similar to where we were in 2015 with Duchenne, where those trials were positive. They just were too small. And the key is we're going to need a few more trials before we get approved. If it was 10 years from now, I would be shocked. If it's 5 years from now, I'd say that's good. Truthfully, if it's 2 or 3 years, I think that's when the first few will start rolling out.
That's wonderful. And Dr. Wicklund, I look back at my life and, I started having symptoms at age 6 and I got diagnosed with 2I in my early 30s. And I think to myself, I lived the majority of my life with no hope of any kind of treatment. And we are on the brink of so many amazing things. I want to share too with our patient community, you can actually get a copy of the new LGMD News magazine by signing up at the Speak Foundation for LGMD Patient Network. And you can actually get like updates on all of the research and research on all forms of limb girdle are in that magazine, and you'll see that, and feel free to sign up to get a free copy of that. We also have a couple of pre-submitted questions that were sent in. I guess they're surrounding the COVID virus and vaccinations. I wanted to ask you to weigh in on that for our patient community. Is it safe for an LGMD patient to receive the COVID vaccine?
So we've had these discussions before. So my answer is yes. If patients have limb girdle muscular dystrophy and they have any cardiac or pulmonary involvement, that puts them at much greater risk if they do get COVID-19. And thus far, we have not seen that there is a difference between somebody that has limb girdle muscular dystrophy and somebody that does not have limb girdle muscular dystrophy. And our recommendation for most of our patients is they should get the vaccine. So as I facetiously say, death by COVID-19 versus vaccine, go for the vaccine.
Okay, thank you. And then as a follow-up, some of the patients also asked, is it possible that getting the vaccine could affect my potential involvement in gene therapy in the future?
And the answer to that is I'm going to come out more so on the no side. It shouldn't affect it. So that means you should get vaccinated because two reasons for that is first is that even if it does have some impact, it's for a theoretical impact for a theoretical drug in the future. So there's no way to know that for sure. And again, getting COVID-19 is much worse than having that potential risk. And then the second is the FDA or the CDC had some webinars, and the mechanism by the two vaccines that are coming out first, the Pfizer and the Moderna, they actually do not go into the nucleus. So they stay in the cytoplasm. And so that makes it unlikely that they're going to have an impact on any of the gene-based therapies.
Okay, thank you. I think these are questions that are really relevant right now for the community. We have some more questions submitted. Does stem cell therapy work for LGMD2A?
Well, that's a really good question. I'll answer it this way. My mentor first started doing stem cell direct injection into muscle back in the mid 1990s. And the answer is we still have not been able to get stem cells to be effective in any of our muscular dystrophies. At some point, there's some logic that we should be able to get stem cells that would incorporate and regenerate muscle, but we have not been able to do that thus far.
Thank you, Dr. Wickling. We have a question from a parent suspected, and she said, is the troponin level, does it have anything to do with LGMD? My son's newly diagnosed and is still waiting on genetic test results, but his troponin level is higher than the average person.
Yeah, so that's so the troponin has to do with cardiac muscle, and the worry sometimes is that means that the heart. We think about troponin being associated with heart attacks, but if there's any sort of muscle injury in the cardiac muscle, you can see an elevated troponin. So it's not uncommon in muscular dystrophies that have high muscle enzyme levels that do have some cardiac involvement, meaning of the muscle, that you can see an elevated troponin, but that does not mean that the heart is at risk of, for example, a heart attack. It doesn't mean there's a heart attack happening. It just means that it's a surrogate marker, just like the CK or creatine kinase level is for skeletal muscle. That's a surrogate marker for some involvement in cardiac muscle, but it's not something I would be worried about.
Yeah, on that vein, the other blood test results that tend to come back irregular for muscular dystrophy patients, do you mind just running down a few of those? Because
Sure.
I think a lot of patients get irregularities there.
Yeah, so the other ones that are commonly abnormal are the AST and ALT. They're called liver function tests, but that's a misnomer because as our trauma surgeon colleagues know, there's about 10 times more of those enzymes in skeletal muscle than in liver, but we tend to see it in liver disorders. But if the muscle enzyme level goes up, so the creatine kinase level goes above 500 to 1,000, you will see elevations in the AST and ALT. Importantly, there's one enzyme called a GGT, and a GGT is liver specific. And so if your AST and ALT are elevated, you can help your doctor by saying, what about my GGT? And they'll look at you quizzically, and then they'll look it up, and then they'll check it. And if it's normal, then the AST and ALT came from muscle and not from liver.
Good, thank you. That's very helpful. We have a question submitted from Jasmine. Is it true that the more physical therapy you do, the faster the progression of limb girdle? And how can we keep the muscles that we have? And is it possible to gain more?
Good questions. So the answer is, we're going to say as an overarching statement that exercise is not bad for the limb girdle muscular dystrophies. I'm going to make that first blanket statement. I'm going to put a caveat on that, and that is in dysferlinopathy and anoctaminopathy, there is some evidence that says that those who are more active may have faster progression of disease. But what we don't know is did that activity do that, or was it these patients were just more active and that's why they had faster progression? And then the final thing you're sort of getting at is exercise, can it be beneficial? Can you build muscle? And the way I talk about it is if your muscles are, let's say, 70% the strength of your peers, most people can gain 10 or 20% more muscle strength with exercise. I will always say you should not start a powerlifting program or do P90X. That is not a good idea. But remaining active and then doing exercise that's sort of modest or mild, that's reasonable. And anything that takes away gravity can be very good. So water-based activities are great if you like water, because you can get a very good workout in the water without putting a lot of stress on your muscles.
Okay, that's good. Good answer. We have a question from Meg. The gene therapy shows the proteins come back. With this therapy, does it just stop the progression, or is there hope that muscle strength will be returned?
That's a really good question also. So the answer is, I think we should just say that our hope is that we stop progression or slow progression. If we happen to get improvement, that would be great, but and there probably will be slight improvement with gene therapies. I think that's being seen, but I don't think we're going to get full resolution of strength back with gene therapies. So the best of worlds would be that we get, well, the best of worlds would be that we regenerate all the muscle, but I don't think that'll happen with gene therapy. But I think if we see that there is some improvement in strength, I think that would be great, but I don't think we're going to restore normal function in muscle with just gene therapy, because by the time you're weak, you've lost enough muscle that you won't be able to do that.
Okay, thank you for that answer. We have a question about chiropractic care, and is it safe to get massages for LGMD?
Yeah, so I have no objections with chiropractic care because if it makes you feel better, that's great. And then massage, I don't know of any contraindication to massage. I don't know why that would be detrimental. Okay. And if anything, it may be beneficial if your muscles are weak and they're fibrosing some, to actually stretch those out may allow you sort of better function.
That's a very good point. Very good point. Because contractures can be an issue with limb girdle, and we will have a webinar with some wonderful physical therapists in the future. So when we do that, I'm sure we'll talk about that. We have a question from Sarah Kay. Do you see patients in your Denver practice? And if so, she had a question about biomarkers, what they were.
So we do see patients. We welcome, and I don't think I mentioned that, but all the GRASP LGMD sites are also clinical care sites. So that's anywhere across the country. So yes, we do here in Denver see patients with LGMD. And then the question about biomarker, I'm not sure I fully understand what they're looking for, but as part of our trials, we will collect a number of different biomarkers, whether that'll be serum, it'll be genetics, it'll be, in some sites we're doing MRI imaging. So there are a number of markers that we'll do. And it also is probably LGMD subtype specific as to what we'll be looking for.
Okay. And then we have a question about losing weight with LGMD. Is there a safe way to do that?
That's I'll go to the extreme of that, which is there's very good data that says that for patients who are obese, and whether that's a body mass index of 40 or 50, so quite overweight, there's no reason that bariatrics is actually so bariatrics is okay in patients who have LGMD. And I think I've had 2 or 3 patients who were quite large that decided to do bariatrics. And the advantage is that you can, in bariatric surgery, is that you'll lose the weight of the adipose tissue, but you should not have a huge impact on the muscle. And when your muscle has to carry less weight, you become functionally more active. In terms of weight loss, I think that if you have the ability to remain active, that will be helpful. And then to meet with a nutritionist to talk about how can you have a reasonable diet that will allow you to slowly, successfully lose weight, that would be the best route.
Okay. We had a follow-up from one of the questions, and when she was asking about biomarkers, she wanted to know, are you seeing anybody for the 2I study?
That's a really good question. Today or 2 weeks ago? So
I think she's meeting, maybe she's regional to your area and thinking
yeah.
she can come to your site.
Yeah, no, we're happy to have her. I was being a little bit facetious only because of the uptick in the number of cases here in Colorado. Observational trials at our institution have been turned off for new enrollment for the next whatever time period. My guess is that by February we will be turned back on. So the answer is yes, we welcome anybody that would like to participate.
Okay, great. We have a newly diagnosed family, and she asked, how common is it that LGMD coexists with other types of myopathies? And this is a good question, I think.
Ooh, I will say that I don't think I have appreciated many cases where there are other myopathies in association with LGMD. I have seen other neurological disorders with genetic muscle diseases, and I think I've 3 cases of patients who have both multiple sclerosis and a genetic muscle disease, whether that be a limb girdle dystrophy or Becker muscular dystrophy. But I can't say that I've seen a lot of patients that have both. The only other thing that I would think that might be thought of would be someone that has like a statin myopathy, so somebody that's using cholesterol lowering agent that can also cause a myopathy. We don't think that it's going to be more likely to cause a myopathy in you, but since 15% of people get muscle symptoms when they're on a statin, then it's not unlikely that someone with LGMD would also get muscle symptoms.
That's good. Do you know of any clinic or researcher that's looking at that, LGMDs and myopathies together or independently?
I don't. Yeah, the only name that came to mind that kind of fits in that mold might be, oh, maybe 2, would either be Tom Lloyd at Hopkins, because he does more myositis, but he also does the muscular dystrophies, or Tony Amato at Brigham and Women's.
Okay. Okay, and then we have a few questions that came in through our chat feature. One question was, what is a SLP therapist?
Sorry about that. Speech, yeah, it's a new name. I used to call them speech therapists, and they like speech and language pathologists.
Gotcha. Okay.
And they're involved in.
I wondered what that was.
I'm sorry about that. So they're not only just speech, but their main purpose for us is that they help with evaluating swallowing.
That's right. And if some patients can have that, and the clinical term for that is, can you share what that clinical term is? I think it starts.
Oh, dysphagia.
Dysphagia.
Right.
That's right.
Yep.
Are there any GRASP trials for patients who are not ambulatory anymore?
Yeah. So I don't think that we've restricted our trials thus far to ambulatory. Treatment trials may wind up being, but those of us on the research side are pushing hard for companies to not restrict trials to those that are only ambulatory. The advantage of ambulatory is you have that as a marker that you can follow, and those that are not ambulatory, but there are other ways that we can follow progression of disease in patients that are no longer ambulatory. So most of us in the network are pushing companies that if they say we want to do a trial, we're saying, okay, what are we going to do for our non-ambulatory population? So we're on your side.
I like that. Great. Would it be possible to map or inventory one's muscles so that an exercise regime can be built around the good muscles to strengthen them while avoiding the dystrophic muscles?
Yeah, so that's a very good question. The answer is, and that's a very enlightened question too, because you do understand that certain muscles can be more affected. So the answer is yes. And a good physical therapist is able to create a program for you that will allow you to make sure that your joints are stretched to the point that they need to be so that you don't develop contractures, but also give you programs that will allow you to adequately exercise those muscles that remain strong without overworking the muscles that are weak.
Good answer. And then we had a question about high CK levels. And I'm assuming because of the new nomenclature, high CK affected some of the labeling. So the question was, do some doctors not include CK in a diagnosis?
If that was the question, not include CK in a diagnosis. If you have a limb girdle unless you have a genetic diagnosis already, or unless somebody is very forward thinking and goes straight from doing your history and an exam straight to genetic testing, which we're encouraging, most of the time a creatine kinase at CK level will be checked.
Okay, all right, thank you. And then we had one last question, and thank you so much for just answering all of these. Would having a defective muscle repair mechanism mean that one's muscle stem cells are used up more quickly because of the need for replacement of lost muscle?
Really good question. The answer to that is probably yes. The two disorders we tend to think about are dysferlinopathies and noctaminopathies. And you would think that you would need to use those satellite cells, which are the repair cells, and they are limited in total quantity. Yes is the answer. So you might think that would be the case. But I don't think that anybody has a good trial that has shown that that is the case. That's it's hard. So when you do science, you like to say what you know, and then you also like to tell people what you don't know. And the theory is that it would be true, but we don't know that for sure.
Okay. And then we had one last question. A patient asked, they have low pulmonary function tests where their forced vital capacity is lower than normal, and they said around 70% supine, and their MIP and MEP are low. 55 is their MIP. Questioned about, do you think that person needs some type of ventilation?
So usually the way I talk to patients is twofold. One, when I'm looking at somebody sitting in front of me, all I know is that their breathing capacity is somewhere between 100% of predicted and 50%. And we know that because if somebody gets lung cancer, you can take an entire lung out of a person, and in day-to-day just living, not running, not sprinting, not exercising, they're not short of breath. Unless they live in Leadville, which is 10,000 feet. No, but the whole point is the average person is not short of breath with one lung missing, which is about 50% capacity. So most patients, if they have 70% capacity, will not be short of breath, and they probably would not need help with ventilation. I will say at night, that's a different story, because when you lie down, there are some mechanical and physiological things that make the diaphragm work harder, and some of the other muscles actually not work during sleep, which is normal, which could make it so that you might need help with breathing at night. But if you have a 70% capacity, 70% predicted, then you should probably not need daytime ventilation.
I just want to say thank you so much, Dr. Wicklund, for the wonderful Q&A you just did. And I just want to remind everyone, if you're newly diagnosed, you can go to limbgirdle.com and find out more information about limb girdle muscular dystrophy. We also want to thank you for joining us today. You can also see more of our webinars in our GRASP LGMD series at the speakfoundation.com. Have a great day, everyone, and God bless you.